Thanks, Kevin. Thank you, Kevin, and thank you for inviting me to present today. So I'm going to just tell you our perspective and tell you how we're practicing medicine with whole genome sequencing. So if we can move forward with this. There we go. I'm going to start with acknowledgments. I think the most important part of this is there's only 3 physicians on this slide. Everybody else is involved in helping the practice of medicine. So if you think how we practice medicine is going to change, you're absolutely right. Everybody in the middle is involved in the informatics side. So I think we're going to see a lot of activity around this. Liz Worthy has developed our software, and David Bick and David Dimmick and Gunter Shar do our clinical diagnostics, along with our 2 genetic counselors, Reagan Veith and Jenny Gertz. So Nick Volker, many of you have heard this, some of you may not have, so this is how we got involved in this in July of 2009. This is what Nick looked like at 2, where he was quite healthy before his disease process started. This is what Nick looked like at 4, where he was in the process of dying, and we were asked to see if we could sequence his genome. So in 2009, we could read an exome for $75,000 in about 6 weeks and about 6 months of analysis, and we were able to come up with a diagnosis that he was diagnosed with a functional defect in the XIAP protein that caused an immune dysregulation syndrome, rapidly resulting in early onset and rapidly progressing catastrophic inflammatory bowel disease. Nick had been in the operating room every other day for 6 months dealing with this disease. And so the bone marrow transplant was done. Nick was on TPN, total parental nutrition, for 9 months. He hadn't eaten. Here he is 42 days after his bone marrow transplant, having a steak. I'm happy to tell you that Nick is doing very well. It's a little bit of an old picture, but Nick had turned 9 in October, and it's a great story. The human story, if you haven't read it, the Pulitzer Prize winning story is called 1 in a Billion, A Boy's Life, A Medical Mystery. So that's how we got involved in this. I always knew that genomics could change the practice of medicine. This just proved that it could. And so we've been driving forward on how do we do this ever since. So we have built a full-fledged clinical enterprise around this. We've had to build everything from scratch because we started doing this in 2010. We now have 3 geneticists who are involved in doing this and 2 genetic counselors that are completely dedicated to this overall program. Now, we built for whole genome sequencing. And one of the questions around this was, well, why do you need to do this when all the information is actually in the exome? And in fact, your success with Nick Volker was in the exome, so why do we need to be able to do this? Why not just do it? And this is before the $1,000 genome was advertised. So what turns out is that we can argue that it's cheaper and you can sequence more individuals, but guess what? Exome sequencing misses a lot of stretches of the DNA, and I'm going to show you exactly how much it misses as we go through. You could perform whole exome sequencing and then reflex into whole genome sequencing, which is, in fact, happens in some cases. And it might save money, but as the price point drops, it's going to not save money any longer. It's just going to be one price all the way around. But when time's of the essence, one of the things that happens in these diagnostic odysseys is they go from test to test to test to test, each one with an extended period of time in between. So we think we can do faster. And so we're already reporting that the number of cases can actually be improved in success. So we're seeing about a 25% increased success rate by doing whole genome sequencing. And we're going to learn more. There's a lot more things that are missed around that. So I'm going to just give you just a little bit of data. So this is from using BWA GATK analysis. So if we go in and we take the same 25 people that have had whole genome sequenced and whole exome sequenced, and we go at 100x coverage, what we're actually seeing is we end up missing 212 actionable elements. That's just 212 sitting in the middle. These are known diagnostic endpoints that are being missed, 212. Whole genome sequencing is actually missing 4. 1 that's unique to whole genome sequencing, and 3 that are in common with exome sequencing. And you can then go in and start imagining that depth of coverage isn't going to save you if you're not capturing this. And we've looked at different captures and different strategies. We're still finding different entities around this. So from that simple point of view, we think it's a major advantage around doing whole genome sequence even before whole genome sequencing. Now, mind you, we've done 115 exome sequences in the last 6 weeks clinically. because that's what the insurance companies are paying for. So you have to do with what you can get. And so while I'd like to do more whole genome sequences, we have to go with where we're being led. So establishing causality is what everybody worries about around this. So we have to determine whether this variant in this gene is causing the disease in this case. Okay? It's an N of 1 medicine. We do need to consider annotations that impact the variant and function on what is expected to happen. Is the variant real? Does the frequency of the variant match the expected frequency of the disease? Is the variant known or likely to cause deleterious, to function? And function impacted by the variant is associated with the phenotype and the underlying analysis. Now, mind you, there's a lot of information out there, but it's very focused and often isn't in place to do what we need. And is the level of evidence sufficient for clinical reporting? Remember, this is not a research project. We're looking to make diagnoses. So one of the things we had to do is we had to rebuild software to take information out of the electronic medical records and turn it into a timeline where we could link genotype to phenotype. And in many of these diagnostic odysseys, there's thousands of pages of information that you now have to get into a place where we can look at this. So the care team can manage, when did this happen? What tests were done? What do people think it was along the medical continuum? So we've had to build whole software to be able to do this. And then integrating this information allows us to look at what's causing the variant. Now these are the guidelines by the ACMG, which is, has it been reported previously? It's recognized the cause of the disorder. That's pretty easy. You hit this one, slam dunk. It's pathogenic. It's previously unreported and is a type that's expected to cause the disease. It's likely pathogenic. Nick was in fact likely pathogenic. There had been no evidence that this gene would have anything to do with gut disease. Then there's previously unreported and is the type which may or may not be causative to the disorder. It's a variant of uncertain significance, a VUS. This is in fact the #1 game you find when you go in and do whole genome sequencing. What do you do with this information? Previously unreported and probably not causative of the disease, likely benign. It's likely because it could still cause disease and we're just not aware of it. So you have to be pretty careful with moving to saying that it's not causal, okay? Very careful around that. And previously reported and recognized as a neutral variant, which is benign. And you'll be shocked that that's actually not a very common category. We need a lot more information around what is benign and what is not causing disease. And you have to be able to enable the physician. Giving them a terabyte of data is really not very useful for a 7.5-minute contact with the patient. So in fact, this is our report. It's generated around this. And this, is there a pointer on here? Yeah. So this little section right here, this is the interpretation, and this is the recommendations. Now there's pages and pages and pages after this of all the things you have to think about. But this is actually what they use for this information. As somebody said yesterday, you need to have 15 seconds of getting in front of the attention of the physician. That's what they have time for. It's not a criticism, and I think we should be careful not to criticize the clinical team that's doing this. They have to meet very strict guidelines on how they push through this. So it's all possible. It's all able to do this. But one of the things I want you to think about is we never talk about patients. It's great to see some patients here yesterday. So here's a video. It was done for marketing purpose, so I apologize for that. But I want you to listen to the family and the care team around what the value of genomics is. If you could start that, please.
Our whole life, since Lillian's been born, has been kind of like a roller coaster ride. She was born at 30 weeks, 1 pound, 4 ounces, 11 3/4 inches long. She was ill several times in the NICU. She was tested for Shwachman-Diamond syndrome. She's been tested for cystic fibrosis. She slowly stopped eating anything by mouth, and we just did tube feedings. She's had 3 colonoscopy endoscopies. I can't even remember all of the different things she's been tested for. Many institutions. They had been seen by many doctors. They'd been seen by geneticists. They've been seen by all sorts of other subspecialists.
She had been through so many different tests, and with them all coming back negative, I think that at times that they wondered if they ever would find a diagnosis.
She became sick in fall of 2010. I remember looking at her one day and feeling like she was dying in front of me. She had gone from 24 pounds to 18, and they couldn't figure out what was wrong. So that's when we came to Children's.
You know, the whole concept of the whole genome sequencing was new to us.
Genome sequencing is a process where we examine or we look at all of the genetic material, all of the DNA, all of the instructions that a person has.
Its purpose is to help us diagnose children when we've not been able to find a diagnosis before. Many physicians suspected she might have a genetic condition.
She really fit many of the criteria of a patient who had an unexplained disorder and for which there may be potential treatment strategies.
Genomics is almost our fulcrum, if you will, to the reach out to the many specialties that our genetics program supports.
One of the remarkable aspects of whole genome sequencing is really the range of patients that we've been able to help. Patients with intestinal problems, patients with immune problems, patients with neurologic problems, patients with cancer. The list goes on and on.
If they could find something that would tell us why Lillian is who she is and why she has the problems that she has, that was our number one thing.
Anything to give her a better life. When we finally found the molecular diagnosis for Lillian through her genomic sequencing, we were just ecstatic. I couldn't wait to pick up the phone. I couldn't wait to call them.
She's the first child that's been diagnosed with this in the United States. She's unique. The diagnosis is unique. We have an answer. It gives something for the specialist to continue to look into to see what they can do to better help us.
Lillian has made tremendous progress over the years. Every time I see her, she's doing better and better.
By doing the whole genome sequencing, we don't have to keep searching. If it weren't for Children's Hospital, we're not sure if Lillian would still be here with us today.
So one of the keys around this is that, first of all, we had a snafu on the video, so it was filmed incorrectly and we fixed it. It was actually done with Illumina, not PacBio, so there was a snafu with the wrong video that went forward. So just to make sure we're clear. All right. So it turns out that the story actually was a little bit more complicated. It was not this TTC37 that was implicated in the disease process before, but rather we thought that this SKIV2 was the causal thing, but there was not enough evidence, even though it was a binding partner. So the clinical team made the decision that it's interesting, but not enough evidence. And months later, a paper came out that actually was able to show that, in fact, this was the right mutation. So what would happen if this mutation hadn't come along? So we've now found a potential drug for Lillian, okay? But it's in a phase 2 clinical trial for a different indication, and we can't get access to it. No complaint about the company, that's just where we are. But then we have real things that end up happening. We've had whole programs that's been published. You can go in and find this. And we've had a whole host of different disease processes we've been through and where we've been able to make a diagnosis. But you'll notice there's a lot of these variants of uncertain significance. So what do you do with this? So we're thinking about how do we change the practice of medicine, where you got to think about this, because here's a real case that just came in on October 23rd. There's a kid in the ICU who's actually on heart-lung bypass, and it turns out that we found a mutation in the FOXF1. And it turns out that it was a variant of uncertain significance, although it was predicted. So what do you do with that? Could we turn this into a zebrafish test? Could we turn it into a cell test? Could we do this in time to save this child's life? Turns out that somebody knew somebody who had a compound that was being used to treat mice. But it hadn't been done in GLP, hadn't been done in any clinical trials, and nothing could be done in time to save the child's life. So we're starting. We're in the right process, but we have a lot more to do to be able to go forward. So one of the things that we've done, we've just been funded by the Keck Foundation to go after variants of uncertain significance, using gene editing strategies to be able to change mutations and model systems very quickly. Here's just a proof of principle. where we have a gene that causes SHRM3 that causes renal disease. So you put the morpholino in for SHRM3 in zebrafish, and it leaks out the fluorescence. If you put in a normal human variant, you actually rescue the phenotype. And what we did is we changed this one single nucleotide, which changed this amino acid, and now we can show for sure this is a functional defect. So how do we do this? Better, stronger, faster. That's really where we're going on this. So I'm going to finish then by summarizing that we offer the clinical laboratory services. So if you're interested in getting into this, mind you, you're going to move down the road to the directions where we are. We have a clinic for adults and children. We're making a diagnosis 25% of the time. And I'm going to argue that actionability includes the value to a family that doesn't have to go from physician to physician to physician, even though there's not a treatment. And if you doubt the clinical utility, I challenge you, do the experiment. Do 20 cases and then tell me whether or not you have. I'll be happy to publish if you don't show that. How do you define function at the pace of clinical need? And how do we find drugs for therapy with an N of 1? Thank you for your attention.